webinar series called The Cutting Edge, which is the brainchild of Dr. Meenu Agarwal madam, who is the president of POGS, who has recently finished her term. So I would like to congratulate Dr. Meenu ma'am, Vaishali ma'am, and Charu ma'am for having a very successful, great year. And I was privileged to be a part of it. So congratulations, all of you. And we also have Meenakshi ma'am with us, Dr. Aarti Nimkar, who's the president from yesterday. She's in the US. She's not been able to join. So Dr. Meenakshi madam is the new general secretary. And Dr. Amal Lunkad will be joining, who's the secretary. So we have this webinar with both the recently retired team and the upcoming team, and we are very privileged to have all the guests of honors and the chief guest, Dr. P.K. Shah sir, Dr. Ajay Mane sir, Varsha Baste madam, and our eminent speaker, Dr. Bharti Rajshekhar. We are very happy to do it. We've been doing this with different societies every time. So today we are doing it with Amravati and Akola Society. So I welcome you all for the same. We would like to have a short prayer song, if it's possible, Mr. Prasad.
Shubham Kurutvam Kalyanam Arogyam Dhanasampadah. Shubham Kurutvam Kalyanam Arogyam Dhanasampadah. Shatru Buddhi Vinashaya Deepajyotir Namostute. Deepajyotir Namostute. Shubham Kurutvam Kalyanam Arogyam Dhanasampadah. Shubham Kurutvam Kalyanam Arogyam Dhanasampadah.
Thank you. Now I would request Dr. Vaishali Chavan madam to introduce Dr. P.K. Shah sir, our chief guest for today.
Thank you, Dr. Madhura. A warm welcome on behalf of Pune Obstetric Gynec Society to everyone present. And we are truly honored to have such esteemed big names of Foxy with us and such esteemed faculty with us. So it is indeed a great honor for me to introduce none other than Dr. P.K. Shah. Sir is a big dynamic leader of Foxy. And sir has held so many posts. He has been president of not only Foxy, but of IAG, IFUMB, MOGS, AFTT. Sir was also dean and head of department at LTMC at Science, where I was fortunate to be there when sir was head of department there. He was also head of department at St. GS Medical College, Department of OBGYN. He is past chairman of Imaging Science Committee, Foxy, and he's also past dean of Indian College of Medical Ultrasound. Sir is joint secretary, Images, and sir is past editor of yes, sir, you have received so many lifetime achievement awards and you have delivered so many orations and talks, and you're the master and the final word in imaging, sir. And we have all learned and we've been learning over the years from you. So we're truly, truly honored to welcome you here today. And we would like to hear from you, sir, and to receive blessings from you.
Thank you very much for your kind words.
Sir is very approachable, very loving. And imaging science, we have to see him doing an ultrasound. I am very keen to do one live workshop in Pune and invite sir to do the ultrasound.
100%.
He's so good. He actually, the Imaging Science Committee, I think, became popular only after sir took in charge of Imaging Science Committee. So thank you very much, sir, for being the mentor for all of us, sir.
Thank you, Meenu, for your kind words. And I wish to thank Pune OBGYN Society, Dr. Aarti, Dr. Meenakshi, Dr. Amol, who are the office bearers of Pune OBGYN Society, and obviously Dr. Meenu Agarwal, who is a past president, immediate past president and convener of this cutting edge webinars that she is carrying out. Also, Vaishali Chavan, who is a past chair of Perinatology Committee, and bubbly Charulata Bapwe, Chair of Study on Female Breast. It's also nice to see, I think, I don't know how and why, but in majority of the places when I am chief guest, Ajay Mane is the guest of honor. This must be the 15th time that Ajay is with me as a guest of honor. So I'm sharing this platform with him and Dr. Varsha Vatsek, who is the VP elect of Foxy. And not only that, we're going to have two very good talks today on diagnostic hysteroscopy for all, going to be covered by Dr. Meenu Agarwal. And Dr. Bharti Rajshekhar is going to talk on intrapartum care for joyful motherhood. Not only that, but it's so nice to see the present president and past president of Amravati OBGYN Society and the president and secretary of Akula OBGYN Society. Because I'm going to visit both these societies in the last week of April, Amravati and Akula on 27th and 28th of April. So it's nice to see your faces, at least because it's very difficult now to remember everyone's face as newer and newer generation people are taking over as chairpersons. So it's nice. One good thing I want to tell you, Meenu, is that it's a very sweet and short program. Because I have seen some of the webinars going on and on and on, and sometimes it becomes very boring to keep attending it for 3.5, 4 hours. So I'm very happy to see that it's between 4 and 5 only, and you have only 2 talks. So I wish you all the very best to you, Meenu, and Dr. Bharti for all your future endeavors, and do well and shine and join us in Foxy's mainstream. Thank you very much for inviting me to be a part of this webinar, and I wish you all very best. Thank you.
Thank you, sir, for your blessings.
Thank you, sir. Now I would request Vaishali Madam to introduce Ajay Mane, sir.
It's a great pleasure for me to introduce none other than Dr. Ajay Mane, who is a great friend to all of us and who's truly an inspiration because not only has he, achieved such a high rank status in Foxy, but he's very much there to help all of us with his advice and with his friendship. So Dr. Ajay Mane, as
Vaishali, we can skip that, no problem.
no, is the medical legal
We'll save
expert.
time.
He's the member. NIMC. No, just few things, because we all know that you're medical legal expert, but you're also member of NIMC, PCP entity wing of Government of India. So that is also a very high achievement. So congratulations on that. You've been also past president Aurangabad OBGY Society, ex-superintendent MGM Medical College, Aurangabad, and health advisor to Sports Authority of India. So many achievements. And I think when you were chairperson of adolescent health education, AMOGS, and also when you were chairperson of Foxy, you received the best committee award. Truly inspiring. So a warm welcome to you. And we request Dr. Ajay to say a few words.
Thank
Yeah.
you.
Also, he's very, very warm and very helpful. Yeah.
Thank you. Thank you, Meenu.
Thank
So
you.
they are very near and dear friend of mine. So they are telling too much things about me. So this is the love of Vaishali, Meenu, Charu, and Pune OBGYN Society, Amol, of course, Aarti ma'am, and Meenakshi. Respected P.K. Shah sir, who is a guru of gurus. So I am very fortunate. Sir said abhi ki at least this is 15th program. I am fortunate enough to be with sir. ये उनका बड़प्पन है कि वो मुझे साथ में ले लेते हैं. So such a legendary personality he is. जैसा Vaishali said and Meenu said, he is a pioneer of sonography for gynecologists. So he is a Bhishma Pitama for all of us. So that is the post only which is suitable for P.K. Shah sir. So sir, pranam. And our senior most president, vice president elect, Baste ma'am. Then Pranjal ji, who is my elder sister. Then Suyega, very good friend again from Amravati, and Bharti ma'am, who is a president elect for Kasoga, and Shyam Kumar sir, Prerna ma'am, and of course Madhura, who is after me since morning. Sir, please give me CV. Sir, please give me CV. She is witchery. So I'm so sorry, Madhura. I sent it very late. But such a lovely people, and you call me every time, and I'm there. As Shah sir said, it is very crisp and beautiful program. Only 2 topics, and the important things is to be told. Otherwise, also after 40 minutes, no one is bothering about the topic, and no one is bothering about the things and who are saying. Scientifically, also after 40 minutes, concentration is gone. So Pune people are very clever. They keep it very practical things, and they kept it after 4 o'clock. 1 to 4, they are shut down. So congratulations, Pune people, and thank you very much for calling me. The topics are very great: hysteroscopy and how to be happy in ANC, because the psychological conditions and the nutrition, these are the 2 best things which modifies your pregnancy, ongoing pregnancy. And now I'm very happy that we are coming to that facts nowadays. So thank you very much for calling me. Best luck.
Thank you, sir. Thank you.
Thank you, sir. Now I request Charu ma'am to introduce Varsha Baste madam.
Yes, indeed. So, after the fantastic introduction and fantastic words by 2 of our strong pillars of Maharashtra, Dr. P.K. Shah sir and Dr. Jay Mane, it is my pleasant duty to introduce the 3rd pillar of Maharashtra, none other than Dr. Varsha Baste ma'am. So once again, we are in a dilemma whether to introduce. Can we have the CV slide, please? As to whether to introduce her as the Vice President elect, whether to introduce her as one of everybody's best friend, or whether to introduce her, wait, madam, wait, whether to introduce her as the one who organized the most fantastic trips when she was the International Academy Exchange Committee chairperson, or whether to introduce her as a kind of a mentor who told me, yes, Charu, go ahead, you must contest for the elections, and we are all with you. Or whether to introduce her as the diva, who's always so fantastically dressed and who gives us so many tips about life, So she is a mentor for curricular as well as extracurricular stuff. And so, madam, words fall short for me to, introduce you. You've been the Foxy Champions Award you've won. You have been the first one to have your ICSI baby in North Maharashtra way back into 2003. You've been the past president of the OBGYN Nashik Society of Nasik. And, really words are falling short, madam. And we really would want you to bless our webinar and bless Dr. Meenu Agarwal and give her all your support for her, for her future endeavors. So over to you, Varsha ma'am.
Thank you so much, lovely Charu, all my friends, beautiful girls. I have got a WhatsApp group, Varsha Baste Fashionista group, and all of them are here. Thank you for inviting me, and I'm feeling privileged.
फैशनिस्टा में हमको भी ले लीजिए. देखिए हमारे शाह सर की
सर आप शाल जोड़ी में से देते हो, हम आपको नहीं ले सकेंगे.
So, ma'am, am I allowed to put this screenshot in Fashionista?
Yeah. Yes. Sure. For one thing. We talk there except academics. Okay, but you are allowed, privileged. I'm really privileged. I'm feeling really feeling proud and happy to be amongst you. Dr. Meenu Agarwal, Dr. Vaishalu, my favorite, Dr. Charu, everybody is my favorite. Even Dr. Amol hai, wo bhi mera bahut favorite hai. He's such a nice person, very humble. What should I say about Amol? Namaste, sir. Dr. P.K. Shah, sir. You are really Bhishmacharya of Foxy, and you have been guiding force for all. And I've seen your ultrasound topics and lectures I have attended, and I was really impressed by your depth of knowledge and giving nature. My
Thank you.
co-chairperson, Dr. Ajay Mane. What should I say about him? He is such a lovely person, always helpful and वो बहुत humorous होता है, तो light atmosphere बहुत एकदम light कर देता है. And the topics really definitely I would say दो topic रखे. Good बाबा, बहुत अच्छा किया. Diagnostic history none other than by मीनू अग्रवाल. और कौन अच्छा कर सकता है इसमें? और मेरे दो बहुत सुंदर beautiful ladies, Pranjal and Suyoga are there to chair the session, and also beautiful Bharti Rajashekar. उसका नाम भी ऐसा है ना, एकदम heavy president elect of Kasoga. She is such a person with in-depth knowledge and एकदम articulate person है. And I have met Dr. Shyam Sirsam and also Dr. Prajakta Jagtar, because during my election period, everybody helped me. I'm really thankful to everybody, each of you helped me. And the beautiful Madhura Kelkar, she was calling me off and on. And so thank you so much, everybody. And I'm really happy to be amongst with you all. And over to you, organizers.
Thank you, Varsha ma'am. Always a pleasure to meet you virtually or in reality, and hope that we meet soon.
Yes, sure. Thank you so much.
Thank you. So with that, we declare that the inauguration function is over, and we now proceed with our clinical program. Over to you,
Yes.
Dr. Sudha.
Thank you. So let us start with our first session, where Dr. Meenu Agarwal would be talking on diagnostic hysteroscopy for all. So for the session, I would like to call upon our esteemed chairpersons, Dr. Suyoga Panat and Dr. Pranjal Sharma. I request Meenakshi Deshpande Madam to introduce Dr. Suyoga Panat.
So on behalf of Pune Obstetrics and Gynec Society, I welcome you all stalwarts here on this platform, which Dr. Meenu Agarwal Madam has started for this cutting edge webinars, which is a very good project. And I welcome Dr. Suyoga Panat now to this dais today. She's a very good friend of mine. We have met before, and I welcome you, Suyoga, to this platform. She's fellowship in advanced ART. She's past president of Amravati Obstetrics and Gynecology Society. She is the recipient of MS Signature International Award, late Mrs. Trupti Umranikar Award, Shailaja Chaudhary Award for Academic Excellence, Wonder Amoxian Award, and also Pudhakar Sanman 2022-23 for working in the field of HIV and AIDS. She has worked at Government Hospital for 12 years. She was the member of advisory board of PCPNDT committee at Amravati. I think we had met way back during our PCPNDT committee meetings and during the lecture programs. Yes, when I had come to Amravati over there. Member of Ethics and Medical Legal Committee of FOXI 2020-24. Member of Aesthetics and Sexual Committee of AMOGS 2022-24. Presented papers and was invited as a guest faculty at various conferences. And yes, a special interest in the mission Beti Bachao. So we have met over a very common platforms over the past few years.
Yes, ma'am.
So welcome,
Thank you.
Suyoga, for this
Thank you, ma'am.
welcome webinar.
Thank you.
Over to you.
I would like to request Charu Madam to introduce our next chairperson, Dr. Pranjal Sharma.
So I came to know Pranjal because she is a member of our Study on Female Breast Committee of FOXI, and I found to be a very interesting and wanting to do so many things kind of a person. She's an MBBS DGO from Mumbai. She's the director of Sharma Hospital, Amravati. She's been the zonal coordinator of AMOGS 2018-2022, chairperson of the website and publication committee AMOGS 2022-2024. She's received a number of awards like the Champion of FOXI Award, V for Stree Puraskar, Best Paper Award at FOXI 2022 and NARCHI, and she's been attending so many conferences, national as well as international conferences. So we are happy to have you as our esteemed chairperson today, Dr. Pranjal, and over to both of you, Pranjal and Suyoga, to conduct the academic session.
Thank you, Charu Madam. Thank you for nice words. Thank you.
Thank you, ma'am.
So I request Dr. Pranjal Sharma madam to introduce Meenu ma'am, and then we would have her talk.
Good afternoon, everyone. I'm indeed honored to introduce someone who really doesn't need any introduction, Dr. Meenu Agarwal madam. Just to fulfill the formality, Dr. Meenu Agarwal madam is immediate past president POGS, elected secretary general, International Society of Gynecological Endoscopy, Foxy Imaging Science Committee chairperson from 2018 to 21, bachelor in reproductive endoscopic surgery, European board certified, course director endoscopy and ART training courses in UAE. She had over 12 publications in international journals. She's first author of 4 books and authored many chapters. Bachelor in reproductive endoscopic surgery, European board certified. Madam has many awards to her name. India's Greatest Leader by Asia 1, Icons of Health by Times Group, Inspiring Gynecologist of West India by Health World, Foxy Champions of Foxy Awards. It's always really wonderful to listen, madam. I have personally heard her on 2 or 3 forums. So over to you, madam.
Thank you so much, Dr. Pranjal, for this kind introduction. And I thank PK Shah sir for such lovely blessings that he gave us. Dr. Varsha Baste madam, Dr. Ajay Mane sir. So thank you very much for taking out time and joining. And thank you, Dr. Suyoga and Dr. Pranjal for chairing the session. And also the incoming team, Dr. Amol, Dr. Meenakshi and Dr. Aarti madam. I think I'm very happy that we two teams have kind of joined hands, and then we are continuing with the program that we started in my tenure, and we will continue in this tenure as well. So I think it is always a continuation rather than we do start with new programs as well, and the old programs we continue with those programs. So that is how the work goes on. So today I shall be talking about basically hysteroscopy for everyone. Hysteroscopy now, like we say, transvaginal sonography is like doing a PV. So hysteroscopy is actually can be just like an office procedure looking into the inside of the uterine cavity. Now, if we actually look at the history, we can do hysteroscopy either as an office procedure or as a either an operative procedure or under anesthesia. When we look at the history, actually hysteroscopy started much before laparoscopy. But as the time went by, the hysteroscopy took a back seat and the laparoscopy became more and more popular. Main reason for this was that we did not have good distension systems available. And then came, of course, many brilliant brains. They came together, the technology and the medical biology brains. And that is how the distension systems were developed. And in 80s, then slowly and slowly, hysteroscopy also became more and more popular. Now, there are 2 types of hysteroscopies, all of us know. One is, of course, you admit the patient and you do the hysteroscopy, whether it is a diagnostic hysteroscopy or it is an operative hysteroscopy. And the second is that you can do an office hysteroscopy, again, both as diagnostic and as a operative procedure. Now I will tell you कि कौन से procedures हम office से कर सकते हैं, कौन से procedures के लिए हमको anesthesia देना है, and how to, what are the basics of diagnostic hysteroscopy. तो मेरे anesthetist भी sometimes he says कि madam, we should have more hysteroscopic training courses, because many a times he finds that the distension is not good, they're not able to see, and the small tips जो help कर सकते हैं how to distend the uterine cavity. So why did this start with office hysteroscopy? Number one, of course, there was a costing problem, because the moment you admit the patient, immediately the costing goes up. And when we look at the Western countries, they had problems with the insurance companies, they had problem with the manpower, shifting the patient from the OT to outside, all that requires manpower, and they had different issues. So that is how the fat hysteroscope, like 4 millimeters was the minimum size. Now it is coming, then 2.9, 2 millimeters. Now we even have 1 millimeter hysteroscope which is available. And जब हम office cystoscopy करते हैं, do we think that does the patient get pain, or the patient does not have any pain? So when we look at this particular anatomy and the nerve supply, see, every woman bleeds every month in the menstrual cycles. The whole of the endometrium is shed off, but she does not get any pain. That means the nerve supplies are ending just at the junction of endomyometrium. So the endometrium is not supplied with nerves. So when she is shedding off her endometrium, the bleeding stops immediately. There is no pain. It only tells us that small procedure, suppose chota endometrial polyp hai, we can take it out and she will not get any pain. When will she get the pain? Because of the distension. So we have to keep the distension pressure slightly on the lower side when we are doing an office procedure. Now, whenever we are doing an office procedure, you see here, one channel is for the hysteroscope, right? And then there is another channel which is for your instrument. तो आपके एक जगह से hysteroscope जा रहा है, दूसरी जगह से आपका instrument जा रहा है. Very, very important to understand that you have to manage parallel. There is no angle. So जब हम laparoscopy करते हैं, we can put two instruments because there is an angle. But here there is no angle. They are just running parallel to each other. So that will help you in the manipulation of your instruments if we just understand this concept, right? Now, whenever we are going in an office hysteroscope, again, the same thing. We must not touch the walls of the cervix. If we go without touching the walls of the cervix, patient will not get any pain. Another thing, it is a 30-degree scope. Okay, so suppose this is the round thing opening that you see. If you enter in the center of the opening, you will actually touch the wall because the center is 30 degree. It is not a 0-degree scope. So always keep this opening in the peripheral, eccentric in position. Okay, so in a retroverted uterus, it will go posterior. In an anteverted anterior, in an anteverted position, it will go posterior. So this is how right side or left side. So that is again very important to understand. So this is how we are going external os, internal os. Then we look at one ostia, and then we look at the other ostia within office hysteroscope. So here, when we say office hysteroscopy, no speculum, no tenaculum, we go with vaginoscopic approach. Now, one thing I would like to again tell, there may be, some PG students listening to this lecture. One thing is very, very important. One is that when you're doing a vaginoscopy, tell your nurse to just take a mop and keep it on the vulva so that the saline does not come back. Let the vagina get filled up with saline. Then you identify the cervix. Cervical tissue is different than the vaginal tissue. You are very easily, you can see. Once you see the cervix, then you just follow and you will find some mucus plug, some blood coming out if she is in her, fourth or fifth day of her menses. And then you can do a hysteroscopy. And the third thing is, do office hysteroscopy under anesthesia, first 30, 40, 50 cases, and then you start doing office hysteroscopy without anesthesia. Because if you're also stressed and office procedure, patient is also stressed, then it becomes difficult. It may become difficult for you to do the procedure. Another thing we should understand, now internal os, if you look, it is oval in shape. Okay, so the newer scopes with the shield, with the outer sheath, they are oval in shape. Earlier, what we did in late 90s and early 2000, they were round. So we had to dilate the cervix and then place it. Now with this oval shape, it is much better. Now, if you look carefully, there is an opening here. Okay, in fact, there are two openings here. One is for the instrument and one is for the inflow. And these holes are for the outflow. Okay, now inflow is going near the fundus and outflow is coming out from the lower part of the uterine cavity. So if you by mistake connect inflow and outflow ulta, then what will happen? The outflow will happen from here and inflow will happen from here, and there will be no distension. So these small things that we have to always keep in mind when we are assembling the entire instruments. The light cord is at a 30-degree angle. Okay. So if you see here, I'm sorry again. Okay. If you see here this diagram, 1 minute. If you see here, if your light cord is facing down, you are looking up. So once you're inside the uterine cavity, you don't move your scope left and right. You have to just move your light cord. Light cord goes left side, right side, up or down, and you can scan the entire cavity. Always scan in 3 positions, all 4 sides. That means 12 sightings you should do inside the uterine cavity, fundus, mid cavity, and at the level of the isthmus. And all 4, just by, even in an office procedure, you can do these 12 sightings without any pain to the patient. So this is how, as I said, that if your cable is down, you are actually looking up. And as you move the light cable, you can see left, right, up or down very comfortably. Again, why do we need a 30-degree scope? Okay, suppose we had a 0-degree scope. What would happen? To see the left ostia, we had to move the scope left. To see the right ostia, we had to move the scope right. Now, with the 30-degree, we can just move the light cable. Okay, light cable right side में किया, we can see on the left side. Right cable left side में किया, we can see the right side. And but with the 0-degree scope, this is how we would have had to move the scope. Yet there may be sometimes deep-seated ostia you may not be able to check. Just one question from the audience: where will you use 0-degree scope? So we will discuss it in the end. All right. So whenever we are doing a office cystoscopy, we can, of course, see and treat the patient. Before that, we should have done a good ultrasound. Now, PK Shah sir is here. Imaging combined with either hysteroscopy or laparoscopy is a deadly combination for us to treat the patient. Very, very good. Deadly means very good combination for us to for the patients. Suppose we find a very thickened endometrial lining, we just push little normal saline with an IUI catheter, and we can see beautifully here, we can see the polyp floating here. Now, when I am putting my office hysteroscope, I know what I'm expecting here, and I can just dissect this at the base and come out. Again, when I said that you should keep the opening at 0-degree at an eccentric level, this is what I meant. I think now see, I'm entering here. This opening is here posterior and not in the center. So whenever you're placing an office hysteroscope, keep this opening always eccentric, and patient will not get any kind of pain if you go slowly and if you do not touch the walls of the uterus. Small procedures like, like here you can see small synecdoche on the lateral wall, very comfortably we can do as an office procedure. These are very old videos, but they are still there in my laptop, so they keep showing up again and again in some presentation. So all this can be done. Patient does not get any pain. Good counseling of the patient before the procedure, and these can, especially pre-IVF patients, they don't want to take anesthesia again and again. They are frustrated with multiple tests and surgeries. So sometimes an office procedure really works well. Sometimes you may find that the internal os, there is no space to enter. You see here, this is the internal os. There are all adhesions here. Initially, when Dr. Betoki was talking about office hysteroscopies, he said you place scissors from the other end and you open the blades of the scissors, and that is what will open, or you cut the additions with the scissors. Later, he realized and he changed his position statement, saying that don't use scissors, use a grasper instead, because there is a possibility that you can create a false passage with the scissor. So instead of that, in fact, if I'm not able to go anyway into the uterine cavity, I always go as an office procedure. Even if the patient is under anesthesia, I can create better, I can enter in a better way. So I'm just see here, I'm only putting my grasper here, just rotate the grasper left and right, open it, and then you will find a place, and then you just follow that opening again in an eccentric position and enter inside the uterine cavity. So this is how it is possible to then enter in a difficult case without creating a false passage. So if you put a dilator, there is always a small risk that you can create a false passage. So that is very, very important to understand. Sometimes you may find big uterine synecdoche. It looks like a septum, but these are thick uterine synecdoche. These can be managed as an office procedure, but sometimes these may not have been diagnosed on ultrasound. You go office procedure, and then you can put the patient in to be done as under anesthesia. So small polyps, you can either, when you are put in a diagnostic scope, whether as an office procedure or as a under anesthesia. No, very important to understand. No, whenever you are cutting a polyp from the base, okay, again, please, the senior people, don't mind it. I'm just giving very, very basic tips here. Always use scissors with one end static and one end moving. Never use scissors with both the ends moving. So again, where will we use scissors with both the ends moving? Will be only for septum. That is where you can also use a 0 degree or a 12 degree scope. So these are the only one indication where you will use a 0 degree or 12 degree. That is when you have a uterine septum. And again, same indication for the scissors with both the blades moving. So when we are buying, we must look that what scissors we are buying. Keep one scissor static and the other blade moving, and you will not perforate if you go, and even for Asherman's. So again, keep one static and cut under vision with the other, because you cannot see both the blades when you are cutting most of the times in hysteroscopy. So this is how you can cut at the base. Before you use scissors, always do a color Doppler. If you have a single vessel supplying to the polyp, then the base should be coagulated. Because if you don't coagulate the base, this polyp has 40% chances it might come back. Then your patient is going to come back to you and say, after 2 months, doc, you did my surgery, and why my polyp has come back again. Again, in office procedure, sometimes you may find now this patient both has, again, not picked up on ultrasound. She has a small septum and she has polyp in both the ostia, and it looked like very, very thick endometrium kind of thing at the fundus, but it turned out to be septum with both polyps on the other side. So whenever we are dealing with fibroids, again, very important is to map the fibroid. Exactly kahan fibroid hai, which fibroid we are going to remove, whether they are removable hysteroscopically or they are not removable hysteroscopically. All of us have heard of many problems happening with the hysteroscopic myomectomy. So that is a very important thing that we must do a good classification. Okay, it is not just that whether the size of the fibroid, it is also where the fibroid is located. You can actually grade the fibroid, what is the size of the fibroid, FIGO 0, 1, 2, how much it is protruding inside the uterine cavity, whether it is flat, whether it is round, whether it is at the fundus is most difficult difficult. Newly you are doing. Don't do a fundal fibroid hysteroscopically. Lateral wall fibroids are easier to do. So you score them like this. And if the score is more than a particular score, then that means this should not be done. And 5 to 7, 4 to 5, it is a complex hysteroscopic surgery. Should not do it. And when it is 0 to 4, these are the surgeries. The beginners can do it, or beginners should actually start with only diagnostic and then move to small, low complexity surgeries. Sometimes we have a problem which fibroids to remove, especially in infertility. So we should be very, very clear that small fibroids, which are submucosal fibroids, they should be removed before the patient goes for either IUI or IVF. However, intramural fibroids, and you see, this is a completely submucous fibroid sitting right there. Sometimes before you actually start the surgery, put a small scope, just take the full view and then dilate the cervix and put the resectoscope and go ahead for the surgery. And as I said, now whenever we are doing the surgery for these fibroids, always, I mean, the newer generation, of course, knows bipolar is safer than monopolar. Go for bipolar when you're buying new system, and always keep the loop under vision. आप सबसे ऊपर भी जा रहे हो, पर under vision loop रख करके लाना है. And suppose you feel that आपका वो खत्म हो गया, you have left, it is over, but it is not cut completely. Then with the whole contraption, you can come down and complete the slice rather than leaving it halfway. And then they keep on hanging and then you don't know what to do. Again, this is a Bugatti shaver. As our webinar is called Cutting Edge Webinar. So we should know about all these tissue retrieval systems. This has a suction and a morcellation. So, but you have only one foot pad, right? How will you do both suction and we don't have two? You cannot use 2 foot pads with 2 feet. So when you press the foot pad once, it starts the suction. You press it again, same foot pedal, it starts both suction and morcellation. So very beautifully designed by a good friend, Professor Bugatti. And it is a good system. Only thing is it is quite expensive. And now I think they are bringing the costing also down. Sometimes in the patients of infertility, even FIGO 1 or FIGO 2, FIGO 2 is completely inside in the intramural, right? But touching the wall, touching the endometrium. So here, if you have a good understanding of ultrasound and your hysteroscopy, so you can simultaneously do the ultrasound, or you can have, would have had a good mapping. So you know exactly, you can give a nick all around with scissors, expose the fibroid. After exposing the fibroid, then use a myoma screw and we can pull it. So what happens when we pull it? From FIGO 2, it becomes FIGO 1 or FIGO 0. And then you use a resectoscope to do it. Excellent for patients who are for ART, for IVF, but they don't have time to wait to go for laparoscopic and then wait for, 4 months for the embryo transfer. So these are some, and of course, subserous fibroids need not be touched. Intramural fibroids, plus minus, you have to take your good judgment. There is no clinical guidelines but fibroids which are intramural and touching the endometrial cavity, those are the fibroids which need to be removed. Isthmocele, another entity which we should keep in mind. More and more patients are coming with isthmocele. So it is a defect at the isthmus level. That is why I said you look at the fundus, mid cavity, and then at the isthmus. So for all the budding hysteroscopic surgeons, whenever you're doing a hysteroscopy for a patient who's had a C-section, just take your light source down at the level of isthmus, and look whether you can see an isthmosil or not. Even if she has no complaints, your eyes will get tuned to looking for isthmosil. And then if you really have a patient who is diagnosed with isthmosil on ultrasound, and she has postmenstrual bleeding, foul smelling discharge, or she has infertility, so those are the patients that you can. So this is how, again, we just took it on this. This is how this again an isthmosil there. And of course, you can also do, even as an office procedure, we have done lateral metroplasty in some patients, especially patients with infertility, small uterine cavity, small endometrial volume. This is a bipolar hook. Especially, I got it made from PB Surgicals, and it really works fine. You don't need to change the solution. Just in a normal cell line from the side channel with an office hysteroscope, whether you're doing it without anesthesia or under anesthesia, you can give this. Always mark, a mock mark, and then go ahead and then you can give a nick on both the sides. Then, of course, we have a publication on the use of PRP, and Dr. Sandhya today is not joined us, but the use of PRP, she was with me when we were conducting this study, and we published it in the patients of infertility, where we inject the PRP in all the 4 walls. And we also published our results where in patients where we had to cancel the embryo transfer because of thin endometrium. So one again, I'm sorry, these are so this I think I can skip. This was our publication. This is how the PRP should be prepared. Earlier I used to prepare with just one 8 ml thing. Then in Dubai, where I also do some courses with First IVF Center there. So this is how they are making the PRP. Then I came back and then I started using this technique. And I found that my concentration of platelets in the PRP improved much more, and the results were much better. So then we changed our technique. So every time you go, you are going to give a lecture, but you come back learning something from there. So this is what happened with this particular thing. So thank you very much, and thank you for patient hearing. And if there are any questions, we can take it. Thank you so much. Thank you.
Excellent talk, madam. Respected Meenu madam. Simply, I've become a fan of your talk now. The language was so simple, it was so lucid, and the video demonstration was so fantastic. The small basic tips which you emphasized, they were so practical, and it will be a great help for all of us who are here in the webinar. Thank you very much, ma'am. Thank you. Any questions? If there are, we can take the questions. And I am really thankful to Charu madam for giving me this opportunity, and we can take up the questions if there are any. Yes, sir. Mane sir wants to ask.
Yeah. I don't have any query, because every query is been cleared by Meenu in a very excellent manner. She has given all basic things clearly. 1, 2, 3, 4, 5, 6. पहले के बच्चों को कैसे पढ़ाते हैं उस तरह से she has taught. It is
Exactly, sir.
beautiful lecture. And see, I am a student of Nozer Shirier sir for hysteroscopy and laparoscopy. He taught me in 1998 in Wadi Hospital. And you are the second person whom I admire after Nozer sir. After hearing at least 500 or 1000 lectures, you are the best teacher after Nozer sir. Thank you very much.
Excellent talk, Dr. Meenu Agarwal, and really lucid presentation with great videos and take home practical messages. वो गाड़ी बीड़ी जाती हुई आती हुई बहुत अच्छा, वो बचपन में fit हो गया. And even if we are doing it day in and out, we could get some more take home messages with your talk. Thank you so much.
Thank you, Varsha. Thank you, Ajay Mane sir. Thank you.
Thank you, ma'am. It was indeed a great talk with a lot of practical tips and learning points for all of us. So let's move on to the next session, for which I would like to call upon our chairpersons, Dr. Shyam Sundar Sirsam. I think he's not joined yet. He was driving and I spoke to him. He would probably join in a while. I would like to also invite Dr. Amol Lunkad sir. I request Vaishali madam to introduce Dr. Amol.
It's a great happiness for me to welcome Dr. Amol Lunkad. He is right now Clinical Secretary of Pune Obstetric Gynec Society. And during our tenure, he was my joint General Secretary, and we have really worked a lot together. He's absolutely very, very sincere, very focused, a brilliant mind, very intelligent person who heads all the Indira IVF centers all over the country. So welcome, Dr. Amol, and I request you to introduce the chairpersons.
Yeah, thank you, Dr. Vaishali madam, for your kind introduction. At the outset, let me thank Meenu Agarwal madam for giving this opportunity to interact with all the stalwarts. And as Dr. Ajay Mane sir was saying, that no need of reading the CV, but I would feel that I am learning so much by listening to the CVs itself. So stalwarts like Dr. P.K. Shah and Ajay Mane sir and Varsha Baste madam, once we learn, just listen to the CV, it is so much to learn from them. So definitely, thank you for this webinar, and it is my proud privilege to introduce Dr. Bharti Rajshekhar. She is the incoming president of KASOGA, that is the Karnataka Obs-Gynae Association. Madam is the director at Sahyadri Multispeciality Hospital, Bharti Nursing Home, and she was the director of Indian Red Cross at Hassan, vice president KPMES. Then she was IMA state vice president, again executive member of IMA, the women's wing. She was the past president of Hassan Obs-Gynae Society, and during her tenure as secretary of Hassan OBGY Society, the Foxy Presidential Rotating Trophy was won.
Dr. Anmol, you can cut short the CV. Thank you. I think his network is gone.
I think he was in the low signal zone.
Yeah, I'm audible.
Yes.
Now you're audible again.
Yes, yes.
Sorry, I just. Madam will be speaking on joyful motherhood.
My pranams to all the seniors here. I thank Dr. P.K. Shah, Dr. Ajay Mane, Dr. Varsha Baste for being with us on this very cutting-edge webinar. I thank Dr. Meenu Agarwal and the Pune OBG Society President and Secretary for giving me the opportunity. And I thank all my co-faculty. So without wasting much time, we just heard an excellent lecture, a cutting-edge lecture, I would say, on the nuances of hysteroscopy. But in spite of all the technical advances we have made and we have reached robotic surgeries, where do we stand in giving effective maternal care intrapartum to those innumerable women we come across in day-to-day practice? So just to touch upon this and say, how do we give them joy when they are entering a new phase of their life, that is motherhood? Are we doing it the right way, or what do we need to do? So I will be sharing my slides and be talking about this very, very mundane topic of providing joyful motherhood. Slideshow. So how can we give the joy of motherhood to women just in this very, very physiological process of labor process or a delivery? So evidence has proven that better quality of care at childbirth could avert up to 1.4 million maternal and newborn deaths and stillbirths annually, and significantly improve maternal and newborn survival. So we need to improve the quality of care to ensure patient safety and accelerate reductions in mortality and morbidity. We need to prevent avoidable maternal and neonatal deaths. Every pregnant woman and newborn baby needs skilled care at the time of birth with evidence-based clinical and non-clinical interventions, and it has to be delivered in a compassionate and an enabling environment. However, various studies have proven when they have studied the quality of maternity care, it has been found that in the private as well as in the public, the quality of care around childbirth has been comparatively very poor. And keeping this in mind, the FOXI came out with the Manyata program with the 16 standards. And when they did the initial studies of 140 centers, they saw that only one facility met just more than 12 of the 16 standards brought about by Manyata. There was another recent study conducted in Delhi which found widespread non-adherence to evidence-based practices during childbirth among both public and private health facilities. With the introduction of the Janani Suraksha Yojana, institutional delivery is definitely increased. However, the significant gains were not sufficient to reach our SDG goals. So therefore, we have to look into this and find out where are we going wrong. So though there is a Manyata program, there is a quality improvement and assurance initiative for the private sector and maternity care, still we are seeing that we lag behind in providing quality care to our women who come to us in labor. So these trends strongly suggest the problem in India is quality of care, that improving care quality needs to be made a priority and that greater efforts must be made to bridge the gap between research-supported knowledge and clinical practice. So this assessment was done, and we know these are the 16 parameters brought about by the Manyata to improve and provide quality, uniform, intrapartum birth care to all those women who come to us. So it is necessary that we have to improve the quality of facility-based delivery care and offer to reduce the maternal mortality and morbidity. So joyful motherhood is not, it has to be with care, with compassion, and with effective communication. So we healthcare professionals should use our clinical judgment when implementing recommendations to tailor them to the individual circumstances, to the woman's needs and preferences, and ensure that all these women are treated with dignity and respect throughout their care. So what do we need to do for that? We have to start quite early. Antenatal education about labor is very essential because very many few of us do speak about this in our antenatal care, probably due to time constraints or due to the heavy load we have in our outpatients. But however, we need to make arrangements for this. So we have to tell them what she will expect in the latent first stage of labor, how to work with any pain when she experiences that, how to contact their midwifery team when they are in emergency. And we also need to discuss their preferences. For example, do they want epidural? Are they willing for admission before they go into labor? So these choices have to be discussed and we have to give them the options to choose and record them. We have to educate them on signs of early labor. How do you differentiate between Braxton Hicks and active labor so that they can come in time to get admitted and unnecessary admissions are not needed. And we have to tell them about the recognition of her waters breaking and any bleeding per vagina. Very, very important is this communication skills that all of us need to develop. Make our healthcare assistants also communicate with compassion to all these women who come to us. Encourage the woman to ask questions. If possible, give her time to think about the options. Help her make a supported decision, like we try to explain, and help her make her own decisions. And always obtain consent before carrying out the chosen care, option of care or intervention. So all birth settings, we have to have a culture of respect for each woman as an individual undergoing a significant and emotionally intense life experience. So she should know that she is in control, she is being listened to, and that her choices are supported and she is cared for with compassion. I think this all of us have to inculcate into the protocol of our labor room. Though the technical part of the intrapartum care is always in place, it is in this care and compassion, I think, is lacking in most of our centers. So we have to provide a model of care in each labor room. We have to have a one-to-one care. Do not leave a woman in established labor except if she requests for some reason, and treat all women with kindness, dignity, and respect. And communication is very important. Sometimes we hardly have any time to talk to this woman who is in labor. It is either the nurse or the midwife who is doing it. Even if it is the midwife, we need to train them up so that they will communicate in clear, plain language and confirm that she has understood it, tailor the content and delivery of information to the needs and preferences of the woman, because each woman has a different cultural background, each woman has a different educational background. So let us try to empower and make a supportive decision when this lady is not able to decide on her own. So we have to support her when she cannot make decisions, when support her that she feels confident that there is somebody there to assist her, and support her so that she understands that she can accept or decline what is offered. She can change her mind, and have to establish a rapport with the woman. Ask her about her wants and expectations for labor. Be aware of the tone and demeanor and the actual words you use. Because very often there are various reports in the literature which say that during birth, the women are having a very distressing situation. They are being abused, they have been taunted, and this is not what we need to give our women who come to us for a very important stage in her life. So when she comes first, we have to greet her and her birth companion, maintain a calm, confident, and professional approach, respect the woman's personal space and dignity, ask her how she is feeling, discuss the labor and birth preferences, and discuss and always document that, and ask her about the pain relief options which are available and whether she would like to have any of them, and give her some time to adapt to the hospital environment and make it more congenial with maybe certain pictures, music around the labor room so that she feels more comfortable there. So we have to explain, and of course we cannot, whenever we are leaving the room, we have to tell her that when we will return, when we enter the room, we need to knock and be there, and she knows that we are there. So, and allow a companion to be with her, so that, because studies have shown that having a companion definitely increases the neonatal and the maternal outcomes. So always when we enter, we have this skill transfer where we can teach our nurses to triage the woman into the red, yellow, and green. So see that whether she is falling under the high risk, so that we are ready. Then do the general physical examination. After you explain to her about what you're going to do, take a detailed clinical history and any other risk factors to be marked in red. And after the color code is allotted, we have to examine her for anemia, her high blood pressure, her vitals have to be examined, and then we do the abdominal and the pelvic examination after explaining to her as to what we are going to do. I'm not going to elaborate because all of you are familiar with all these, but these would be ready reckoners for our nursing staff, so that when we receive a patient, they will know what they're supposed to do. The blood pressure has to be checked in the sitting position, and whenever the blood pressure is more than 140/90, they have to be marked red as a high risk group. And of course, the temperature has to be recorded, because increased temperature in labor is a warning sign. So do's and also always check the oxygen saturation. Try to find out what type, if she is leaking or she's passing some fluid for vagina, try to find out what color fluid it is, because the moment it is greenish or reddish, you know that it's an alarm signal. So these are the checkpoints we have to keep there ready, so that the intrapartum care has changed over the years a lot. So see that they change into hospital clothes, provide them with a mask, and maintain the temperature of the labor room. Keep all the oxygen suction catheters and all the necessary things ready. And of course, we have given up giving enema. There is no shaving required, and no routine IV fluids is required for a woman with no high-risk complications, no IV dextrose to be given, no routine antibiotics to be given. Do not keep the mother nude, full or partial. Try to keep her covered and keep her warm. Do not shout at her. Do not leave the mother alone. Do not use the cell phone. This is very important. We need to tell our staff that they are not allowed to use unless it is for communication with the doctor, and do not allow to take pictures of the mother of the baby without the permission of the mother. And of course, this is the regular tray we have to keep for delivery, episiotomy, and the baby tray, along with additional trays of PPH and the eclampsia tray, have to always be checked and kept in place and refilled after use for effective intrapartum care. So once we have checked this, then we do the abdominal examination, and of course we've examined the baby's condition, and then we come to what is the comfort that we are going to give her in labor. So generally, you can encourage the woman to use any position that she is comfortable with. Encourage to have a birth companion with her, because we can have any position. She can sit down, she can be on the floor, she can walk about. Encourage her so that she enjoys and she has more confidence when she's moving about rather than being tied down with IV lines and catheters onto a couch and she's not able to move around. So you can give her a freedom of movement because this will distract mothers from the discomfort of labor. It will release muscle tension and give a mother the sense of control over her labor. So this is very, very important, and continue to give her maternal support. So this one patient, one watch, I think we have to keep in our labor rooms. If not that way, we can always have this labor companion, which could be one of her own family members who will be with her always. So a continuous maternal support, studies have shown that they have a decreased need for pain relief. The duration of labor is shorter by about half an hour. There's an increased incidence of vaginal deliveries. Instrumental deliveries incidence can come down, and the 5-minute Apgar scores also are better when we have continuous maternal support, having a labor companion. So having a labor companion, it could be husband, it could be her mother, it could be her sister, or it could be one of your physician assistants. So then the baby is less stressed, she has less use of pain relief drugs, and she has a better bonding with the baby as well as in breastfeeding. So I'm not going to go into the details of all the management. We have the NICE guidelines as well as the FOXI and the WHO guidelines, which tell us how we are going to monitor in the first stage of labor, how vital signs, and the baby is to be monitored. And the companion is supposed to be there. And of course, before doing any examination, upper vaginal examination, please wash your hands. Asepsis is very, very important. We explain to the mother and wash our hands, use sterile gloves, and then do a gentle per vaginal examination to assess the cervical dilatation as well as the position of the head, the presence or absence of caputor molding, cervical effacement, and presence or absence of membranes. So after we do that, we start assessing them in the first stage of labor by hourly frequency, monitoring the contractions, her pulse rate, her temperature, blood pressure, and respiratory rate, and offer a 4-hourly vaginal examination or in response to the woman's wishes if there is a concern about the progress. You need not go on repeating the per vaginal examinations if you have an effective partogram in place. And of course, eating and drinking, inform her that if she is no risk factors, she can definitely take water or small sips of semi-solid diet can be taken. A routine injections of the proton pump inhibitors are not necessary for low-risk women. However, if you have maybe a possibility for cesarean, you could always give her a proton pump inhibitor like omeprazole. So what do we recommend during labor? Admission in active phase. Have a companion of choice to provide continuous maternal support. Always give her mobility in an upright position. Allow food and drink, and use a WHO partogram to monitor the progress of labor. We do not recommend perineal shaving. You can just do clipping. A routine enema is not necessary. Routine nil by mouth is not needed. A routine IV fluids and routine vaginal douching or routine amniotomy or routine oxytocin augmentation is not necessary because let her enjoy this process of motherhood. So these are what we are not going to recommend. So coming to pain relief during labor, we need to speak to them well in the antenatal period about the options available for pain relief and whether they would like to have any one of them, because it depends that the woman's experience of pain is unique. They have different cultural backgrounds, their socioeconomic status, and their neurodiverse sensation of pain have to be taken into consideration whenever we think of pain relief. We can give them the options like non-pharmacological pain relieving strategies, sterile water injections according to the NICE guidelines, given 4 different injection points around the rhombus in the gluteal region is said to reduce the incidence, reduce the pain concept in these women. Inhalational analgesia like nitrous oxide 50% with oxygen 50% is available in certain centers. Pharmacological analgesia like opioids or pethidine can be used. Regional analgesia like epidural or combined epidural and spinal can be given after explaining to them, taking their consent and telling them what we are going to do and offer them this pain relief. And then, of course, the woman's position, I already told you that she can adopt any position in the second stage of labor. It need not be the regular lithotomy position. She can keep her legs comfortably at the level she requires, and preferably a sitting position, studies have shown, has got a better impact on the vaginal, on the second stage of labor. So during the second stage, let us take into consideration her emotional and psychological needs, assess the progress, assess the frequency of contractions, Perform intermittent auscultation of the fetal heart immediately after every contraction, and always consideration to be given to the woman's position, hydration, coping strategies, and pain relief during the second stage of labor. And of course, your medicines tray has to be kept ready. A checklist has to be there and it has to be checked. So ideally, in the first stage of labor, you're going to monitor the mother, you're going to monitor the baby, and the progress of labor by monitoring the contractions and doing a pelvic examination every 4th hourly and documenting the case record. Of course, most of us do have the partograms in place nowadays. And once she is in active labor, that is after 4 centimeters to full dilatation, we continue and plot the partogram after 4. And nowadays the guidelines say plot it after she is 6 centimeters. And then in active labor from full dilatation till delivery, monitor the maternal heart rate and the baby's heart rate, monitor the contractions and note the progress of the mother. So the recommended practice says routine use of a WHO partograph is necessary to monitor labor and for early identification of abnormal progress of labor. So how do we deliver the head safely now? Of course, all of us are familiar. We need to give good perineal support, try to prevent tears, receive the baby in a warm towel, place it on the mother's abdomen immediately. Don't suction if the baby is crying, and then active management of 3rd stage of labor along with simultaneous breastfeeding if the possibility is there. So a selective episiotomy is what we need to follow nowadays. A routine episiotomy is not necessary. I think we need to keep this in mind, because a non-routine episiotomy, of course, there could be an increased anterior perineal trauma by 84%, provided we have not given proper perineal support and we do not flex the head in the correct position. Only then I think this high incidence. But if we are careful to keep the head under flexion and perineal support, I think we can avoid, and unnecessary fundal pressure, we can avoid this perineal trauma. But this posterior perineal trauma is decreased when we don't do a non-routine episiotomy. 2nd and 3rd degree tears are reduced by as much as 33%. Need for suturing is reduced, and there is no difference in the infection rate. Hence, let us try to have a indicated episiotomy. And of course, we all know that we do the delayed 3rd cord clamping. If the baby is doing fine, please wait for 1 to 3 minutes after birth or when the pulsations stop, and then do the cord clamping. After that, we do the active management of 3rd stage of labor, administration of uterotonics within 1 minute of delivery of the baby, taking care that there is no other baby in the uterus, controlled contraction with counter traction on the uterus, and followed by uterine massage. So once we are done with that, we have to care for the mother after that. So care during delivery, we've already told you: upright position, selective episiotomy, prophylactic oxytocin, delayed cord clamping, controlled contraction, and uterine massage. Then we have to receive the baby in a warm towel, place the baby flat on the mother's abdomen, dry the baby, not cleaning, remove towel 1, cover the baby in a warm towel, the 2nd towel. If the baby is not crying, cut the cord and place the baby in the warmer, and the neonatologist takes over with positioning and ventilation. Do not hold the baby upside down. Don't beat the baby's back. Don't shake the baby. Don't remove the vernix while drying. Do not rub oils on the baby. Do not apply cords, anything on the cord. And feeding the baby with honey and holy water is absolutely no. And handing over the baby immediately is also not recommended. And of course, the waste disposal or disposal has to be done according to the guidelines. And postnatal care, always avoid separating the woman and her mother within the 1st hour of birth. Encourage initiation of breastfeeding as soon as possible after the birth, ideally within 1 hour. Ensure that any examination or treatment of the baby is undertaken with the consent of the parents, and either in their presence, or if this is not possible, at least with their knowledge. And then, of course, routine postpartum care. We're going to inspect the birth canal for lacerations, inspect the placenta for completeness, early resumption of feeding, massage the uterus, prophylactic antibiotics if she has a 3rd or a 4th degree, and early postpartum discharge is to be recommended. You do not do a manual exploration of the uterus. You do not use routine ice packs over the hypogastриum, and routine methyl ergometry is not recommended. So postnatally, you will have to record her temperature, her pulse, blood pressure, respiratory rate, the uterine involution, and the condition of the lochia. Make an early assessment of women's emotional and psychological conditions, because postpartum depression is another very, very common situation. So we need to give notice of her emotional and psychological health also. Check for successful voiding of bladder, because after regional analgesia, usually the voiding may be hampered, and also check for the abeyance if the regional anesthesia effect has gone. And if she is not able to perform a straight leg rise by 4 hours, please inform the anesthetist. So this I've already spoken about. I'm not going to go through this. So in case you have to transfer a mother to a higher center in case of any complications, talk to the woman and her birth companion about the reasons for this and what they can expect, including the time needed to transfer. Address any concerns and allay the anxiety they have. Ensure that her wishes are respected and her informed consent is obtained. Carry out the transfer of care of women in labor as early as possible after the decision. Alert the relevant healthcare professionals at the site at the center where you're going to transfer them, and categorize transfers as life-threatening emergency or urgent, and then provide adequate pain relief. And always see that the woman is dressed and wrapped in a blanket. Ambulance staff or other personnel should be aware that they should not make the woman uncomfortable. Ensure a midwife has been involved with the woman's care till she reaches the point where she has to be taken care of, and monitor her throughout the transfer. And the woman's birth companion should also travel with her in the ambulance so that she will be very comfortable and there is no anxiety, and that will provide a better neonatal and maternal outcome. So to give effective patient care is what we all need to provide. Though we are providing with the technical know-how, we have to respect the patient, address her concerns, address her nutrition and pain management, and give her the independence to choose what she needs. Take her consent for every examination, for every procedure you're doing. Try to individualize the approach according to the cultural, social, and economic reasons, and always consider the patient's views and preference. Do not decide for them. You only guide them and they decide. Always involve the family members and carers. Continue the care and relationship even following the transfer or the delivery, and be open to taking feedbacks and complaints. I think this is what we can provide a positive childbirth experience with joyful motherhood, because mothers expect giving birth to a healthy baby in a clinically and a psychologically safe environment. They need continuity of practical and emotional support. They need kind, technically competent clinical staff who can control the situation through involvement in decision making. So the WHO recommended that respectful maternal care, which refers to care organized and provided to all women in a manner that maintains her dignity, privacy, confidentiality, ensures freedom from harm and mistreatment, and enables informed choice and continuous support during labor and childbirth is recommended. My whole presentation is summarized within this one slide. So these are the guidelines WHO has told us. Give us respectful labor and childcare, give her emotional support, effective communication by staff, pain relief strategies, regular labor monitoring, documentation, audit and feedback, oral fluid and food intake, give her proper mobility in labor room and birth positions of choice, have a pre-establishment referral plan in your center always, and continuity of care even in the postpartum and later is necessary, because all women have a right to a positive childbirth experience. So, because 9 months of good care but 1 day of poor care intrapartum can result in bad outcomes. Your skill matters to her and her family. So more than vaginal or abdominal birth, a positive birth experience matters to them. So let us give them the joy of motherhood by providing them. So all of us can put our hands together, put all these strategies of care, comfort, and compassion and communication into our labor room protocols so that we can save lives, improve health, and transform the futures. So I thank you for the patient hearing, and my namaste to all of you. And I sincerely request all of you to kindly support me for my future endeavor in FOGSI as chairperson of Perinatology Committee. Namaste.
Yeah, thank you, madam, for your excellent lecture. And I'm sorry for the technical glitch which I had, but it was nice hearing to you, and you gave very clear, crisp messages and made really that topic of joyful motherhood clear to all of us, and giving clear guidelines regarding the topics. So if any questions we can have, I don't see any questions in the chat box, but
yeah, I think I loved the way you described all the etiquettes when we are visiting the patient. knocking at the door, introducing yourself. And, these are small things, but very good for the students. Sometimes the students don't even know the name of the patient. Madam, वो myomectomy वाले patient को pain हो रहा है, उसका नाम क्या है, नाम नहीं पता है. So very nice.
And like the hospitality industry, madam, like when we go to a hotel and we check in, the courteousness, I think, has to come into the medical fraternity. That is very, very important. We have to make a change in that.
Absolutely.
Yes.
Thank you, Dr. Bharati. That was indeed a fantastic talk, and it was a pleasure to listen to you. Indeed, respectful maternity is one of the most important things that we as obstetricians must be doing for all our patients, and each and every point of yours is very well taken. So thank you so much, Dr. Bharati. And with that, do we come to the end of this academic session, Dr. Meenu?
Any comments, PK Shah sir? Any comments from your side?
Very well balanced webinar. One gynec topic, one obstetric topic. Excellent teachers who gave us in-depth knowledge of both the topics. And when you talk about Joyful Mother, I still remember way back in 77 when we were residents. We used to have ayabais and nurses in the ward slapping on the thigh of the laboring lady. That was something which was very shocking. Because most of these ayabais and matronis and all those, they're ladies themselves. And when a woman is shouting because of pain, they used to slap. So we decided in the department that they should not be allowed to touch the patient. A houseman or an intern, some doctor has to be there. Because I think we have to respect these ladies. When they shout, it is not that they enjoy it. It's basically because of the pain. And I think unless and until you have experienced this pain yourself, you do not realize what is the amount of pain you get when you are delivering. So I think there are so many things which we need to improve upon in our labor wards. If you remain in labor ward for a longer period, you know what are the negative things that we need to improve. I think what Bharti has covered is something superb. Only thing I wish she had more time to talk, because it's a huge topic now, the joyful motherhood, and with so many international organizations giving their inputs, it has become a very wide subject. And I think we need to ourselves practice first and teach our juniors. Thank you very much, Meenu, Pune OBGYN Society, for this excellent webinar on Tuesdays. And I'm looking forward to these meetings in future also. Thank you. And all the best.
Thank you, sir.
Thank you.
Thank you, sir.
Thank you.
Charu, you can give the vote of thanks.
So,
Sorry. No.
Amol, you were saying something?
No, I said that is what I was saying on behalf of Pune OBGYN Society. Basically, I would like to thank PK Shah sir, Ajay Mane sir, and Varsha Baste madam for honoring us, and excellent lectures by Meenu Agarwal madam and Bharti Rajesh madam. So thanks all the delegates for being here. Charu Vappe madam, if you want to.
Yes, we would like to thank Akola and Amravati societies for being here with us today. Dr. Suyoga and Dr. Pranjal Sharma, thank you so much for being our esteemed chairpersons for today. For some reasons, our Akola people could not join us today. They have their own reasons for that. But we would like to continue these webinars and these sessions. And thank you so much, dear Suyoga and Pranjal, for being here with us today and for sparing your valuable time. Of course, our esteemed chief guests and guests of honor have, really brightened up the screen today by their presence. And thank you so much, Dr. PK Shah. It's always a pleasure to meet you. And of course, click pictures with you. We have so many now. He's one of our, most esteemed advisors of the breast committee, and we really look up to his advice every time. And today also, he's been here giving us his valuable inputs regarding this webinar. Of course, Dr. Varsha Basti ma'am, Dr. Ajay Mane have really been great sources of inspiration, and we thank them for being here. Bharti ma'am, now we're going to keep meeting again and again and again. We were together for our breast webinar also, and today you are here with us for the POGS webinar. So thank you for that. Meenu, as Dr. Vaishali always says, that we are always in awe of you as to how you have so many fantastic presentations ready, and the way you deliver them, the beautiful videos, just goes to show the quantity of work that you're doing. Your post as a Secretary General of ISGE, your post as a past chairperson of the Imaging Committee, and all your contributions, your publications and presentations, your textbooks, all go to show your academic incline and your dedication towards the subject of OBGYN and infertility. So we wish you all the best for all your endeavors. Thank you, Team BSV, for being a partner for this particular session, and we shall keep doing them again and again. Dr. Madhura, your strong shoulders are ready, to bear the burden of all these webinars, and we really appreciate your valuable presence in POGS and for these particular webinars, where you are a strong pillar of support for us, and you make sure that all our esteemed faculty have got their links in time. You have all the CVs in time. So thank you for your presence. Thank you, Vaishali. Thank you, POGS team. Thank you, Amol. Thank you, Dr. Aarti Nimkar and Dr. Meenakshi Deshpande. Thank you very much. Goodbye.
Bye.
Thank the entire POGS team, and we will definitely be associated with you along with Kasoda. Thank
Yes,
you.
indeed. Yes,
Thank you very much, everyone. Charu, Vaishali, Amol, you all are my backbones, totally to walk. So on this path of Foxy. So thank you very much. Thank you, Madhura. Thank you, Bharti Madam, for joining us and giving such a wonderful lecture. Thank you, Dr. Suyoga Madam, for chairing the session and being there for us. Thank you very much. Thank you, Dr. Meenakshi, Dr. Aarti, and of course, Dr. Amol once again for being again associating with the same webinars. So we will be having these webinars for the delegates who have joined every Tuesday, 4 to 5. We've been having. They are quite popular, and we do have almost, in one webinar we had over 350 delegates who had joined in. But definitely they are always in 3 digits. Very good numbers are joining in, and since this is on the same fixed day, fixed time, so this has kind of become more and more popular amongst everyone. We have people from Pakistan, from other countries also joining us for this webinar. So that's nice. So thank you very much. Thank you, everyone.
Thank you, madam. Excellent initiative. Bye-bye.
Thank you.
Bye-bye.
Recording stopped.
Meenu?